I am Dr. Mohammad Kuruddin from National Heart Foundation Hospital and Research Institute presenting acute stent thrombosis. Acute stent thrombosis is a very rare and life-threatening complication of the PCI, and it occurs within 24 hours of PCI, and it is mainly due to procedural related factors. A 63 years old male diabetic dyslipidemic ex-smoker complained of chest pain for 10 hours. He is presenting with acute LVF and with cardiogenic shock, and ECG showed infraposterior MI with RV infarction and rushed to cath lab for primary PCI. And unfortunately, first image was fluoroscopic. I lost it. And RC was totally occluded with thrombus in his proximal segment. RC was wired with floppy wire. And after repeated thrombus aspiration, this was image. And then 3.5 into 28 millimeter disc deployed directly at 12 atmosphere. And post dilation done was with 3.5 into 10 millimeter non-compliant balloon at 18 atmosphere. And this was final result. And that time we think this was quite satisfactory as patient was hemodynamically unstable. And left main was 99% distal segment involving origin of LAD and LCX. And LCX non-dominant free of significant disease, and LAD 99% in its stenosis in its origin with TIMI2 distal flow. And ECG after PCOS, there was resolution of ST segment. And then on the next day, early morning at 6 a.m., patient developed severe central chest pain, and ECG showed ST segment elevation. And we reevaluated our previous PCI final result and revealed that there was a linear dissection in proximal part of the RC just beneath the catheter. And there was intramural residual thrombus in mid to distal RCA. And check CG showed there is since totally occluded with thrombus in its proximal part, and after repeated thrombus aspiration, this was imaged. And then 3.5 into 38 millimeter drug-eluting stent from RC ostium deployed at 16 atmosphere, and post dilation done with 3.5 into 15 millimeter at 10 atmosphere, and then with 4 into 15 millimeter non-compliant balloon at 18 atmosphere, and stent which showed there is a good result. And this was final result. As patient was complaining chest pain, and there was residual, there was stenosis in the left main, and we decided to do stage PCI during hospitalization, and this was after resolution of stent thrombosis, and we checked CG after 5 days. This stent is patent. And there is stage PCI to left main for left main to LAD, quickly wired with floppy wire and from wire in left main to LAD, and predilation done with 2.5 into 50 millimeter non-compliant balloon. And image after predilation, and we think there is calcium also with, we took 3 into 10 millimeter non-compliant scoring balloon for left main calcified portion and inflated at 20 atmosphere. And then 3 into 30 millimeter disc from left main ostium to LAD deployed at 12 atmosphere, and image after stenting. And post dilation done with 3.5 into 10 millimeter and 4.12 millimeter non-compliant balloon at 18 and 16 atmosphere. And this was final result. And image after PCI. Acute, now some words regarding acute stent thrombosis. Acute stent thrombosis is a rare but life-threatening complication of coronary artery stenting. Acute stent thrombosis remains a challenging task for cardiologists despite the application of modern procedural techniques and dual antiplatelet therapy strategies, as well as improved understanding of the underlying pathophysiology. And in our case, there was according to ARC classification, this was definite acute stent thrombosis, and it occurs within 24 hours of PCI. It was acute stent thrombosis, and the incidence of acute stent thrombosis varies between 0.1 to 1.7%, and the clinical consequences of acute stent thrombosis are very severe and could result in up to 50 to 80% acute myocardial infarction and approximately 40%, more than 45% mortality. Multiple mechanisms may be responsible for the development of acute stent thrombosis, including patient-related factors, procedure-related factors, and post-procedural factors. There are several predictors of stent thrombosis: procedural, lesion-related, patient-related, antiplatelet therapy factors, and drug use. In our cases, there was a dissection and slow flow, and the lesion-related factor was there was baseline TIMI flow 0 and more thrombus burden. And this was in case of acute myocardial infarction. Patient had diabetes mellitus decreased LV ejection fraction. After PCI, there was 35% left ventricular ejection fraction and ischemic time more than 6 hours. The Triton trimetral reported that in patients with ACS, prasugrel therapy was associated with significantly reduced stent thrombosis rates, but with an increased risk of major bleeding, including fatal bleeding. The Plateau trial demonstrated that ticagrelor significantly reduced the rate of definite stent thrombosis and probable or definite stent thrombosis without an increase in the rate of overall major bleeding as compared with clopidogrel. However, the Euromax trial demonstrated that the choice of oral P2Y12 inhibitor, either clopidogrel, prasugrel or ticagrelor, did not appear to affect the rates of acute stent thrombosis. So take home message is acute stent thrombosis is a catastrophic and perplexing clinical event related to PCI procedure with multiple etiologies. Further efforts should therefore be pursued to identify patients at high risk of acute stent thrombosis to adopt a more effective preventive strategy, and careful evaluation of final post-procedural image is crucial to prevent acute stent thrombosis as our case. And thrombus aspiration, balloon angioplasty and glycoprotein 2B3 receptor blocker could be a therapeutic option.
Thank you, Dr. Colin.